Okay, we have a new, quite a number, 20 odd questions here. Some may have been answered over the course of the 3 talks, but I would like them to be answered here in the Q&A session. I would direct the questions to either one, and if any of the rest would like to add in, you can feel free before we move on to the next question. Okay, the first one, continuous PNB is not widely used here compared with single shot PNB. Can you share your thoughts on this observation? This is from Anonymous, so I presume maybe Ame, in terms why it is not so popular compared to single shot.
Okay, I think to answer that question, you have to look in, to a lot of confounding factors, I would say. It may be difference in practice, different in surgeon's requirement, cost, and other factors that can influence why continuous technique is not so popular. But from my experience in Hospital Kuala Lumpur, we are a big department. Okay, we have close to 60 specialists and consultants. We have almost 130 junior doctors, and sometimes to train all of them is not an easy job. Okay, and that's one issue. And most of the surgeons, I don't say they don't like, but especially our the arthroplasty surgeon, they prefer a single shot over a catheter for reason they believe catheter always will definitely cause motor weakness. So difficult to me to change the perception. But in summary, it has a lot of confounding factors why continuous technique is not so popular.
Okay, thank you, Dr. Ami. Next question. So basically, when patients who are from the question, I'm just going to rephrase it. The patients who have continuous PNBs, when they exercise, is there dislodgment? So, and what are your solutions to dislodgment or dislocation? Maybe I direct this to Dr. Rasydan.
Thank you very much, Dr. Shah. Okay, for dislodgement, actually it begins for physiotherapy, for which physio, upper limb or lower limb. The one that we encounter every day, the technical part is the upper limb. There is a lot of dislodgement for physiotherapy. So we also been facing that problem with dislodgement. Also complications also does happen, Horner syndrome, despite you put it in supraclavicular catheters. So for physiotherapy, it's a different way to put it, because you need to discuss with the surgeon how long the patient will be kept, and then how's the patient, is he really from a patient yang pandai menjaga, taking care of himself. So most of the time what we do is we try to put along the nerve axis, as one. Number 2, put a glue in. Number 3, you do the double tunneling. And number 4, put the dressing with the oxide spray. That's the most that we can do. And then if you got budget, probably the catheter over needle is one of the best and easiest to put, and less risk of dislodgement.
Okay, thank you very much, Dr. Rasydan. So this is a question, I presume, from our East Asian neighbors. I think I'm not sure which country, yeah. But basically, about putting continuous PNB when patients are on antithrombotics. So, basically, there are guidelines for putting central new axle, particularly on patients who are on antithrombotics. So I think he's just he or she is just asking opinion on this. I open the floor. I open the question to any of the speakers, if you want to, with regards to doing continuous PNB with patients who are on antithrombotic therapy?
I say, with regards to antithrombotic therapy, again, it's all about risk versus benefit. And most of the blocks that we are performing is superficial blocks. If you refer to AAGBI guideline 2016 or latest ASTRA guideline 2018, I think. Yes, they do categorize with blocks whether it's a superficial block or deep block. Inpatient is on anticoagulant, of course. Likewise, just like the neurexia technique are contraindicated, especially for those clopidogrel or thecal bleeding. So for deep blocks, I will also do the same. I wouldn't give. But superficial block, let's say like femoral nerve block, blocks that is if there is a hematoma, then it can be compressed. It may be given, but again is that all these are individualized according to each patient. And again, that why do we need to give a continuous nerve block? A single shot is actually easier to do, technically safer, because continuous nerve block has its own sets of problems, which actually I want to take opportunity to highlight, since I didn't mention in the slides. Initially, I thought the other speakers mentioned. Kindly allow me to just share the slides. All right, everybody see? Like whatever the other speakers has spoken about this. Of course, continuous nerve block, it has a longer procedural time. Like Dr. Rasydan says, sometimes take even 1 hour, especially its operator factor. And yes, there's a failure rate. Failure rate only, there's primary failure rate, secondary failure rate because of catheter, dislodge, the knotting, everything. Technically difficult. There are a lot of cost equipment issue. I think I highlighted in the interscaling block between single and continuous interscaling block, and potential complications I mentioned. That's why these are all the factors that sometimes discourage us of performing a continuous nerve peripheral nerve block. But it looks like, again, for any approach for any patients and for any nerve blocks, we have to go at the justify risk versus benefits and the indication. Are there any other alternative apart from nerve block? I think single shot peripheral nerve block, once again, if it is a superficial nerve block, it is pretty safe. And a lot of time we are caught in this matter because, take example, some patient has a severe peripheral vascular disease, require double antiplatelet or anything, and they have multiple comorbid. They also have gangrene toes. Nerve block seems to be a safer approach, stable hemodynamics, effective pain control. Instead, I don't think there is the need of doing catheter technique if a patient is on double antiplatelet. But a single shot under a reliable hand is actually safe and actually very minimal life-threatening risk. Okay.
Okay, thank you, Beh. Next question. I think this is from Dr. Chong Yen about pediatrics. So basically how, I think he's mentioning the risk of catheter dislodgement as well. Maybe Dr. Amir, since Dr. Amir also did a fellowship in pediatrics anesthesia.
Okay. I think the strategy to reduce catheter dislodgement has been shared by Dr. Rasydan. Whether it's pediatric or adult, they have similar sets of problem, catheter dislodgement, and more so in pediatric where their soft tissue are very thin, and the catheter that being anchored into the soft tissues are very minimal. So to tackle this issue, I don't have a definitive solution. You can try put a glue, you can try a double tunneling technique, but once the patient has no pain and they move around, the tip, although on the skin the catheter is intact, but the tip of the catheter can be displaced away from the target or from the nerve. So I don't have a really good answer for that. Sorry.
Any other points from the other speakers for pediatric particularly?
I hardly do pediatric.
Rasydan?
Same here also. We hardly do. pediatric patients.
Maybe if some of the members of the floors who are doing quite regular pediatric regional anesthesia can contribute.
Yeah, I think whether they can answer, they probably cannot answer. It's very difficult.
Oh, sorry.
Okay. So we'll move on. Risk of, I think it's peripheral nerve damage with, from what I understand, peripheral nerve damage with our continuous technique. If I get it correct from Dr. Du Nguyen. And I open it to the floor, to the speakers. Is the risk higher compared to single shot? I think that's mainly the take-home message that the person is asking.
I think it all depends about Dr. Shah. It depends on who is inserting and what kind of catheters are they using. So if you look at the epidural catheters that we insert for plain blocks and for nerve femoral, usually the risk is almost the same as single shot actually. Of course, what they're saying now is putting triple guidance with ultrasound, nurse simulator, so pressure guidance will really limit, but still the risk is there. But I think it's the same as single shot actually.
Just to add a bit, I think the risk of nerve injury in peripheral nerve block is already, quite low. And with ultrasound guidance, it stays low, or I don't know whether we can bring it lower because it's from 0.04% to 4%, depends which paper you put. If you are using the paper that I've come across before this, interscalene block, to compare whether it's single shot or if there is any risk using continuous technique, so far there's none. And they still quote the risk is still very low, which is similar to the single shot technique. So I reckon it has, so far we have no problem using a peripheral, continuous technique in terms of nerve injury in our center.
I just want to add on a bit of information here. Yes, peripheral nerve injury, it can be due to nerve block and also patient factor and also surgical factor. And as we know that for nerve block related, it is in the article that actually the incidence are very low. But having said that, if you want to do a nerve block using catheter and technique and the single shot, we know that the catheter that we are using are bigger needles, like for example, Tuahi. And it's actually, again, it's operator dependent. And now with the ultrasound, it is supposed to be safer. But although evidence show that yes, ultrasound guidance reduce the loss, but nerve injury is equivocal. But again, it's about the operator. That means when we do the nerve, any nerve block, we try to see the needle wheel all the time in plain technique, and especially the needle tip. If it is a big needle, you accidentally misadventure and pierce the nerve. Of course, the nerve injury will be expected to be more damage. So in any peripheral nerve block, if you are doing in-plane technique, do not advance the needle if you can't see the needle tip. Try to go back to the principle, maintain in-plane, see the needle, or try to get the needle view, needle visualization view. That will at least minimize a lot of inadvertent potential complications.
Okay, thank you. I think we'll move on. There are actually 4 questions from Dr. Kwang Wu Zwan. I think okay, first, I think it's done. I will pick and choose because I think in the interest of time, what's the absolute max for number of days? I think either Rasydan or Beh mentioned this, 48 hours, 2 days, and you must weigh that against the risk of infection. If you refill continuous LA infusion, why and what type? So basically, I think this has also been covered in length. Various patients, various types of surgery and so on and so forth. Okay, but the interesting question from number 3: would you combine? I guess the word is combine popliteal and adductor catheters in patient together in both distributions. Any thoughts?
There are case reports about using combined adductor canal sciatic nerve block. Again, it's all depend on your practice. So far, I don't really require a catheter usually for sciatic nerve block because most patients that receive a single shot, they will be well covered with multimodal analgesia, even systemic opioids post-operatively. Again, cases as according to every individual. Yeah. And whether the surgeons agree with us to do. Yeah. Sorry.
Anybody else want to add to that? Combination of both popliteal and adductor canal catheters.
I would like to add on that. In my practice, if the patient has already received adductor canal catheters, I think the popliteal catheters is a bit overkill, especially if you site the tip of the catheters quite close to the distal adductor canal, which close is very close to the adductor hiatus. And in fact, I've used this strategy sometimes to block the foot and leg through the adductor canal, injecting large volume of local anesthetic very distal to adductor canal. And I think most of the time I will get good spread to the posterior compartment and block the sciatic or popliteal nerve component as well. So if you ask me, I think popliteal catheters in the presence of adductor canal catheters is a bit overkill.
Okay. The fourth question from Dr. Kwang is PENG block. Is there a description of continuous PENG blocks before?
Yeah, I think I shared a case report on a continuous. I think paper from Japan authors that they inserted catheters at the PENG for THR surgery, and they found it's effective and no motor blockage. So I guess the evidence are still in the case reports. Limited to case reports at the moment.
Anybody else, Beh?
Yeah, I said, let's say for THR, there's a new guideline by Prospect about THR. In their guideline, they just mentioned about the femoral, the fascia iliaca, or the alternative. PENG block is still new. It's still at the level of evidence is about case series, case report. So yes, as a catheter, I would say you have to understand it's also a deeper block compared to femoral nerve catheter. You are the catheter placement and also on that segment, it can be technically difficult. So I will go for something that's evidence-based for time being, and also that provide the predictable analgesia for the patient, which is the femoral nerve block or fascia iliaca.
Okay, we'll move on to the next question. But I think from anonymous attendee, growing volumes of orthopedic surgery resulting in prevalence of osteoarthritis, you see increased continuous PNB usage instead of single shot PNB for this indication. I think it has been spoken about, and by all three. I think I wouldn't touch this because I think it's a social combination and choices. There's a lot of recipes out there. It's a matter of choosing it and agreeing it with surgeon and patient. I wouldn't touch this. Okay, why is there rebound pain after single shot nerve block? Ami, since you covered this, rebound pain.
Okay, the concept of rebound pain after regional anesthesia, because it's a single shot at the peripheral nerve. After the metabolism of the local anesthetic and the washout of the local anesthetic from the nerve, 12 to 14 hours, or depends on how much the mass of local anesthetic you injected, the patient will have a rebound pain. So the problem with rebound pain, sometimes it's become difficult to treat because they need become hyperalgesia, and they need extra doses of systemic opioid or oral opioid. So as I discussed, the rebound pain is coincides with the local anesthetic duration of a single shot LA given.
Okay. There's a question from Navin directed to you. I mean, what is your preferred method of post-op analgesia for knee surgeries at the moment? Short and sweet. I mean.
Single shot mid adductor canal block, 20 mils. Continue with PCA morphine post-op. That's my preference at the moment. Of course, plus the multimodal analgesia, PCM, tramadol, or Coxib.
Okay. From anonymous attendee, CPNB for adductor versus femoral. I think Beh covered this, but quickly, Beh, just what is the dose that you would recommend? Continuous for adductor versus femoral.
Okay. Adductor canal block is a canal, so compartment. So we usually require higher volume of basal infusion. As I said, for the bolus, also, if you look at just now the meta-analysis systematic review, Medicine 2020, a lot of the authors, they will use about 20 mil or 30 mil of bolus shot first. Then post-op, they run at 5 to 8 mil per hour. Fairly the same, almost like a femoral nerve block. Again, femoral nerve block also usually we give for me. Okay, not for me. Sorry, I no longer do much of a continuous femoral nerve block. But from the just now the anesthesiology news, all the authors in various established centers, they use ropivacaine 0.2% running at about 5 mil per hour. 4 to 5 mil per hour with the bolus about 4 mil if there's a PCLA running. Okay.
Okay. The next question by Dr. Jian Wei Chin. What is the technique for basically for adductor canal for TKR? Basically, are you going to do it pre, post op, and a bit of I think that's the main question that what he or she is asking. Maybe
pre-incision is the
for TKR, yeah.
Yeah, pre-incision is the way actually. But I say if this surgery is done under spinal anesthesia, yes, you know that intraoperative anesthesia is already covered. So post-operative can still nerve block is still possible. But bear in mind, if you are doing the post-operative nerve block, if patient is using local infiltration anesthesia technique, periarticular, so you have to check with your surgeon the dosage that you are using.
I think the person who's asking is concerned about tourniquet. Is the tourniquet going to disrupt, cause any issues with the catheter around the same area?
You want me to ask, Dr. Ami, do catheter technique?
My routine practice, if I use catheter for adductor canal, I will always insert post-operatively. So yeah, my main concern is also the tourniquet applied by the surgeon might dislodge or might I don't know what will happen to my catheter, because it's the spot that they apply the tourniquet is at the same side of my catheter insertion. So I prefer to insert post-operatively.
Okay, we'll move on. I think this question from Dr. Azmi Abu Hassan, but I think it's all in your talk, Dr. Beh, about the drug concentration, rate of fusion, maximum catheter days. I think we won't address this. It's in the talk. Okay, from Anonymous, any standardized regime for CPNB for upper limb stiffness rehab, bolus 30 minutes, prior physio, with this continuous infusion so I think Dr. Beh, you want to touch on this? Upper limb stiffness rehab.
The manipulation stiffness. I don't really have many patients that require that kind of manipulation. In fact, I think Dr. Rashan just now also just mentioned about one of his case using the manipulation and his LA regime. I think this is a fit for him to answer.
Yeah, it all depends. If you put a catheter for shoulder manipulation, we did a few cases, and usually the ROPI 0.2 5 mil per bolus. even that also we have some also got Horner syndrome, so we go down until 2 mil also. So it all depends on where you put the catheters. So most of the time, it's the smaller volume will be safer.
Yeah, so I just add on a bit to the Dr. Rashdan's answer. Yes, like shoulder manipulation. Yes, again, the idea is that that interscaling groove is a very small space. So any high volume, there's inadvertent risk of LA cause spread, causing the adjacent structure like venous palsy and also dysphonia, Horner syndrome. So we keep a low volume background infusion, or maybe even 2 to 4 mil with the bolus and maybe 2 mil per hour bolus. But like the one that I shared with you just now for the post-op patient basically well covered for the post-op pain up to 24 hours with the regime that's now I mentioned, the single shot chiropractic 15 mil plus the surgeon gave an intra-articular. So I just reserve my LA volume for the next is during physio. Like each bolus is only 2 mil, and that also suffice. Patients are totally pain-free during the physio passive range of movement. Again, it all depends on how well the catheter is sited. Yeah. And interscaling is known to be notorious to be have a lot of catheter dislodgment. It's not easy. Yeah, even Prof. May also had shared before his catheter for shoulder surgery dislodged very early. Yeah.
Right. Okay. The next question: ambulatory continuous catheters. I know most of the speakers have shared their data on that. Anyone doing it at the moment? Ambulatory CPNB? Yeah, it is feasible. It's just a matter of, I think it's organizing a lot of your post-op care, who visits the patient and so on, and where does the catheter get removed. Okay, another one from, this is from another anonymous attendee, about ESP in cardiothoracic surgery, unilateral or bilateral. I think the data seems to suggest bilateral, but any thoughts? Any of you doing cardiothoracic regularly?
I don't do cardiac, but I said if any midline incision, you need a bilateral. Likewise for every laparotomy. But if let's say it's a cardiothoracic like thoracotomy, yes, it's like paravertebral, so it's unilateral. So your RA volume, of course, is you can play around more because maximum allowable dose is higher and volume higher.
Okay. Next one from Iskandar Khalid. With regards to abdominal surgery, midline insertion, do the speakers have any preferred choice of continuous PNB technique, continuous bilateral rectus sheath or QLB or versus step? Maybe one by one, Amir, Rasydan and Beh, what is your continuous PNB, preferred continuous PNB technique for abdominal, major abdominal surgery?
My preference has changed from QL catheter to rectus sheath catheter. Reason I found that at least in my hands, rectus sheath catheter works better. Of course, the QL catheter. There's a possibility to cover the autonomic nervous system as well, but it can also. The visceral pain can always be covered by multimodal analgesia. So I found rectus sheath catheter is better in the sense of covering the somatic pain. So nowadays my preference is bilateral rectus sheath catheter instead of QL catheter.
Rasydan?
For me, because I'm a teaching center, so both I prefer to do both regardless of whatever surgery the laparotomy is, because want to teach that rectus also can be done, QL also can be done with catheters, and then most of my trainees, of course, the easiest is rectus sheath. QL, the fastest that my trainee has done about 30 minutes bilateral, right and left entry approach.
Beh?
Well, for me, for midline laparotomy, I will also prefer neuraxial technique first. That means, let's say epidural is not feasible. Even elective, if it is not a bowel surgery, I may give a spinal intra-articular morphine. But at the end of the surgery, I will give ask the surgeon to infiltrate the rectus sheath. I don't put catheter. Mainly, I think in private practice, it's not easy to monitor catheter. And this is a midline with the 2 catheters or more. And with it's also a cost issue also. Actually, with that, with the neuraxial technique, complement with just like what the Narayanan was sharing in his institution, the famously, we do the GA, neuraxial spinal intra-articular morphing. After that, post-op letter shift, either surgeon deliver. If surgeon not feasible, I will give a single shot. Yeah.
Okay.
And multimodal anesthesia with PCA.
I think 1 or 2 we are. Okay, I think we have 5 minutes more. I'm going to pick and choose because I can't answer everything. I do apologize to those because we've got 12 more open. From Dr. Kweng Wu Zuan, I think this is directed to you, which is quite good because what is the plexus block for clavicle fracture? Since we have written something on it. Okay.
Oh, me? Okay, yeah. We just written something, the scoping review of the clavicular anesthesia, regional anesthesia for clavicle fracture. Yes, for surgical anesthesia, combined superficious cervical plexus plus the interscalene is a choice. There are so many case reports and even RCTs about it. But if you just for anesthesia per se, yes, superficial cervical plexus block is adequate. All this I'm talking about single shot. And of course, there are some patients you are worried about motor sparing or there's a contraindicator for like interscaling. There's a new technique, facial plane block that is in the literature, which is called the clavipectoral facial plane block, and that is also can be an option. But having said that, clavipectoral facial plane block, usually the level of evidence at least so far is just a case series, case report. Yeah.
Okay. Question from Dr. Katina Hanora Japa. I'm a newbie in CPNB and looking for recommendation for electronic pump. Which pump brand would you recommend that would enable me to use continuous technique plus intermittent bolus? Dr. Beh?
I will give you a personal answer for this.
Oh, you okay. Okay.
But actually, I'm okay with any pumps. For me, so far, the CAT Soleus and also the plus the Micra is a good pump. Both of them are wonderful. Even the CATs, take example, Micra, now they have a remote monitoring. That is feasible for overseas that they can, because it's an ambulatory perineural infusion. But for us, Malaysian, we hardly really utilize this kind of additional features. Yeah, both are really good pump. I like it because the key of it is actually lightweight, easier facilitate patient enhanced recovery after surgery mobilization.
Okay, I'm going to choose 2. These are complications, okay, just so that we kind of wrap it. There's Dr. John from Medan, Indonesia, John Franz Sitipu. I think he had a patient where he did interscalene and the patient felt pain during injection, and now post-op patient had motor weakness and sensory dysfunction till 1 month after surgery. What should I do and how about prognosis? Is it temporary? Okay. Maybe anybody has some experience with neurological sequelae complications and would like to give advice to Dr. John? Oh, long slide, tell me.
That's a very sad situation. It's a nightmare for you, John. What should you do? I guess you have it depends the setup of your institution. If in HKL, I would get help from the neuro medical colleagues. Definitely, this patient will need nerve conduction studies to establish the diagnosis. And whether it's due looks like I don't know if I'm correct. Looks like you have caused from the direct injection. You have caused nerve injury from the symptoms that given by the patient. Whether it's permanent or temporary, time will tell. But what you can help the patient is to treat if there is any chronic pain that occurs. The motor weakness, probably you can support by referring them to the physiotherapy. And you have to follow up the patient. I will routinely prescribe some vitamins for the nerve. Don't know. I'm not so sure whether it helps or not. But others, can you chip in some answers for John?
Your answers are quite complete already.
There's also another question from Muhammad Shukri Abud. Similarly, post-sciatic nerve foot drop. I think similar, post-block neurological sequelae. It's a difficult topic. It will warrant another lecture, webinar series. But I think in principle, the four main things that, three main things is ultrasound, nerve stimulation if you're unsure where the nerves is, and pressure guidance. So basically, if you do this well, you should be avoiding 99.9 something risk of reducing the risk of nerve injury. I think with that, we should wrap it up. It's 12:16 here. Thank you, everybody. We still have 439 participants. Everybody's enthusiastic. I do apologize that we cannot answer 12 more. Maybe the organizer Aesculap may collect the unanswered questions and we can answer them separately, either through private emails or through this Q&A session, through Q&A facility. With that, I thank you again. I hand over to Mechu.
Wow, that was a very informative session. Thank you, Dr. Shahridan. Thank you, Dr. Amiruddin, Prof. Rasydan, and Dr. Beh for sharing your valuable insight in the practices. And I would also like to thank all of you attendees for staying with us, although we have overrun 15 minutes. So for all of you, please refer to the chat. There will be a link and passcode for you to generate your e-certificate. And for the Malaysian doctors, please scan the QR code with the MMA apps for your CPD points. Yeah. There will be also a feedback poll. And before you leave this session, we would really appreciate you could spend some moments to give us some feedback. So thank you so much and to have a great day ahead.